Hello, learners. Much of our training as professional counselors is extremely other directed. So, the focus of today's lecture will be our own personal self care. We will look at professional identity and development, as this has a significant impact on our healthcare workforce resiliency. Some of our learning objectives today are to recognize the signs and symptoms of burnout, compassion fatigue, and secondary trauma. We're also going to be talking about the prevalence of these risk factors among counselors today. We'll be looking at trauma-informed care initiatives and explore how self-care is an ethical obligation of counselors. So let's talk about the landscape of counseling today. There is a projected 23% increase in need for substance use and mental health counselors in the field. So we understand that our projections are extremely high. When it comes to quantity and quality of counselors, here we're talking about quantity. We need more people to do these jobs, to fill these positions, but we also need to talk about the quality of people who are doing this job, who are going to be taking these positions, and who are going to be doing the job well. And what that means is that we must also be taking great care of ourselves to be able to sustain and stay in this field. We're dealing with a number of factors that influence the workforce today. Looking at COVID-19, which has caused many of us to move more remotely. With that, while it still is a very good option, you may lose a little bit of that personal connection compared to being face to face in the same office when you're remotely. And that may come with a wealth of different factors, and we need to be very mindful to make sure that we're providing adequate care. There are soaring overdose rates, and we have had more and more overdose deaths annually than ever. There are, of course, numerous health disparities among marginalized groups. Oftentimes, these individuals are misdiagnosed. They often don't even make it to the doors of our treatment facilities. So we have to work to do advocacy and helping people who do experience shame and guilt and history of injustice. How do we engage them so that we can offer them care? We recognize that there is a very high turnover in the field as well. There are some people that say, maybe this field isn't for me, or there are folks who are moving on to different career paths. Whatever the reason for the degree turnover, it does happen very often in our field. And what this means is a disconnection for our clients. Many of us who have worked with individuals that have had numerous counselors, and they're actually getting pretty tired of telling their story. And it can also be traumatizing to tell their story over and over again. You may work with individuals who say, I've told my story so many times. Can you just read my record? I don't want to have to go through this again. And I get that. There's definitely something to be said about developing and sustaining those relationships. So if we're taking better care of ourselves, hopefully we can stay in the field and we can offer improved healthcare for the individuals that need us, and we can build those relationships with them. The regulations in our field are extremely antiquated and oppressive. So productivity, paperwork can be extremely burdensome. It tends to pull us further away from the reasons why we are in the field. We want to help people. However, that comes along with a lot of writing treatment notes, progress notes, group notes, assessments. There's lots of documents that we need to complete, and we have an ethical and legal obligation to do so. So we have to try and find that balance. Additionally, in the counseling field, we see many program-driven type facilities. Sometimes this can cause us to move further away from individualized and tailored care. So how do we meet the needs of the individuals that we're working with? We need to continue to advocate to break down the silos. People often get lost in the system. They're in drug and alcohol treatment, they get clean, their mental health symptoms start to exacerbate. They have to switch counselors, potentially facilities, programs, and move into mental health treatment. In mental health treatment, they see their symptoms start to subside. As a result, they may come back to drug and alcohol treatment, or their symptoms will exacerbate and they might go back to drug and alcohol use. So, that boomerang effect that we have is not quality care. Again, we're not going to solve all of these problems, but I want you to identify and take a closer look at what's happening around you and how you can be a role model, how you can be an advocate, and how you can continue to take care of yourself as well as others. As I mentioned, drug overdose deaths in the United States topped 100,000 individuals annually. Approximately 136 people die every day from an opioid overdose. In 2021, the CDC identified fentanyl as the number one cause of death among individuals ages 18 through 45 years old, killing twice as many people as COVID, car accidents, cancer, and suicide. Importantly, fentanyl was found in 77% of overdose deaths among adolescents. We need to be advised that there are even more gaps in the field as it relates to substance use disorder treatment for adolescents. Yet here we see an increased number of adolescents having fatal drug overdoses because of fentanyl use. Oftentimes, when children are in school, drug use is seen as a mental health issue and not a substance use disorder issue because schools will say, no drugs or alcohol in my school, not in my community, not in my backyard. Obviously, they're acting out. This is a mental health related issue. And so instead, what we really need to be doing is asking difficult questions, having difficult conversations to get the right information to offer the right care. Oftentimes, people are unknowingly exposed to fentanyl use, and this increases the fatal overdose deaths. So, the timeline here at the bottom of the opioid related overdose deaths, they have often come in waves. Most often, you'll hear people talk about the first three waves. Wave number one being a result of prescription opioid overdose deaths. This was a result of the pain scale and having medical society ask people on a scale from 0 to 10, what is your pain? And what happened was people were rank ordering their pain level. And to match that, doctors were prescribing pain medications to a similar level. And we saw our communities just flooded with prescription opiates, and that had been lethal. There was a lot of misuse going on. We have a number of interventions in place now, such as the PDP, which all prescriptions need to go through a system, and that helps combat doctor shopping. It also helps us to look at what doctors are prescribing, what types of medications, where the medication script is getting filled at, and we can cross reference this in terms of overdose deaths. If we look at wave number two, we've seen an increase in heroin use in the subsequent years. Overdose deaths started in 2010. Wave three is a synthetic opioid overdose death, and that was starting to spike around 2013. And this was in large part as a result of fentanyl, tramadol, and other types of synthetic opioids. And what we often don't hear about is this kind of hidden epidemic, and that's wave four of psychostimulants and opioid overdose deaths. So we're starting to see psychostimulants increase, such as methamphetamine and cocaine, and how they're being intermixed with other types of opioids or other substances, thereby making them very, very lethal to individuals and their safety. As counselors, we're sitting with people that have lived experiences or are working with marginalized groups. We have to know that they likely have experienced adverse childhood experiences, ACEs. We've talked about this in a past lecture. And that comes along with having to be able to conceptualize how are we going to provide appropriate treatment and interventions? How are we going to develop these relationships? We don't always know what has happened to a person, but we can conceptualize what might have occurred, and that helps us put in a position to do great work. So let's look at racism as a key structural determinant of health. We also then must explore racial discrimination or race based trauma experiences, post traumatic stress, and a history of unjust medical treatment affecting trust and access to care for thousands upon millions of individuals. The increase in fatal overdose deaths among non Hispanic Black individuals is also soaring. So, that shame and stigma may be keeping individuals very sick. We have to be fully aware of that, extremely mindful of it, and be able to move forward in a way that works best for us and for those that we're working with. So, as I've just given you the landscape of the counseling field, today let's look at what that means for us. As I mentioned, if you're a counselor sitting in a room with individuals or with families, how do you experience them? What is your own lived experience? How might you be triggered or experience countertransference? Let's talk about normalizing these types of conversations in order to offer each of us self care. We'll start with burnout, which is a form of exhaustion among human service workers, chronically exposed to the problems and emotional distress of patients. As professional counselors, we're consistently exposed to problems and emotional distress of others. As we sit with individuals that have experienced trauma, we then start to see some signs and symptoms come up for us, and that may look like emotional exhaustion, depersonalization of clients, feelings of ineffectiveness, or reduced feelings of accomplishments. Maybe we can even call this imposter syndrome, increased arousal or avoidance. You see somebody on your schedule and you're like, oh, I really don't want to see them today. You're walking down the hallway with a client, you see them coming, you hear their voice, maybe you want to turn the other way, you want to avoid them. We start to see this hyper arousal, and maybe our own senses are working overtime because we've been triggered with countertransference, which can be very real for us as counselors. Maybe we're having trouble concentrating, forgetting things, stepping away from things, not being able to complete tasks. All of these are signs and symptoms of burnout. We also begin to look at secondary stress and vicarious trauma. I have them both here because oftentimes these terms are used interchangeably, but secondary stress occurs when healthcare workers feel they cannot rescue or save a person from harm, resulting in guilt or stress or countertransference or maybe imposter syndrome or problems with self efficacy. I think many times beginner counselors in particular feel secondary stress and that we are in this field to help people. We don't want to create harm. So oftentimes we personalize that experience. It takes time to recognize how and when that occurs for us and how to engage in self care planning around that and to set appropriate boundaries. Vicarious trauma, that negative transformation in the self of the provider that results from the empathetic engagement with clients, their trauma, owning this sense of responsibility to help. Traumatic experiences can abruptly rise from specific client represented information. And of course, we cannot forget about COVID-19. That's not that far back off in our history. Sometimes we just need to check in with supervisors, colleagues, use consultation to help and see how traumatic work can impact us, and especially when we can't see it ourselves, which is oftentimes what happens. We are going to need to engage in self care to offer appropriate treatment to our clients, maybe to reinforce some healthier boundaries. We need to be taking care of ourselves. Compassion fatigue is a multidimensional state of exhaustion affecting function in the biological, psychological, and social dimensions, affecting the ability of healthcare workers to care for and about patients. So, if you look at this picture here, this is our fuel tank. Keeping it full to be able to give back is going to be very, very important. When our tank is on empty, we're not able to give back. You've probably heard that saying before of having to put your oxygen mask on before helping others. That's going to be very similar to keeping our tank full so that we can help others. Again, we've talked about this. Our field is very, very other directed. elevated displays of chronic stress resulting from caregiving work that we choose to do when our tank is getting closer to E. When we are looking at our clients as cases or patients or numbers instead of people, that's a sign of compassion fatigue. You start to depersonalize. And in this case, maybe we're looking at it as just numbers and not humans. We're losing that connection. And that is oftentimes a way in which we self preserve, but it's also a sign of compassion fatigue. Maybe it looks like low frustration tolerance. Maybe we become more directive in our counseling sessions, less tolerant in various areas of our professional and personal lives. Perhaps our health starts to decline. Maybe we are self medicating. We see impaired professionals in the field. And again, we are all human. We are not exempt from these things. Addiction does not discriminate. Sometimes individuals come into this field because of their own past experiences. So we have to be careful in our ways of coping, whether that is adaptive or maladaptive. So, what's the big difference here? There's a lot of overlap. Burnout is really looking at the description of physical and emotional exhaustion, especially whenever folks have low job satisfaction. Maybe they feel powerless or even overwhelmed at work. Whereas vicarious trauma, this describes that profound shift in a counselor's worldview. So, this may be the result of working with clients who have experienced trauma, and maybe you become kind of callous or numb. Compassion fatigue refers to that profound emotional and physical erosion that takes place when helpers are unable to refuel or regenerate. So, again, instead of filling up your tank, you're at E and you just keep continuing to work at E. So, when we look at vicarious trauma and compassion fatigue, I want to really emphasize this cumulative occurring over time, and it can be evident in not only our professional lives, but also our personal lives. For counselors, this unmanaged emotional stress response puts us at increased risk. Empathetic occupational hazards, identity confusion, professional identity. Maybe you're asking yourself, am I in the right place? Am I doing the right things? Do I want to be here? Is this the career that I want? Again, we talked about potentially self medicating, or if you are experiencing countertransference. Maybe trauma has been triggered within you. Maybe you're having flashbacks. Maybe you're having nightmares or irregular sleep or eating pattern issues. You are not in your best state. All of this can, of course, be cumulative and cause signs and symptoms of depression, anxiety, or even thoughts of suicide. And perhaps we're engaging in suicidal thoughts, intents, or gestures. All of this can be extremely real for any human being, especially when we're working with individuals who have experienced trauma. So let's talk about some treatment approaches. And I'm going to tell you a little story or a little analogy. So there was a person on the bank of a river, and they would jump in to save someone. And just as they got to that person they were saving and they got them out of the water, here came another person downstream. So they jumped in again, trying to save this second person. And then more and more people were coming downstream, and just this one individual they didn't have the bandwidth to be able to save everybody. And then eventually someone else comes up on the side of the bank and they say, "Hey, can I help you?" And this person says, "Yeah, I don't know what's happening. I need help. Uh, Individuals just keep coming downstream and I just need to keep saving them." So this person on the bank says, "Okay." And they start running upstream. And the guy in the water says, "What are you doing?" And the person on the bank says, "Well, I'm going to see where people are falling in." So the upstream interventions are strategies that focus on improving fundamental social and economic structures to decrease the barriers to help people reach their potential. That person who was on the side of the riverbank and wanted to run upstream, they were forward thinking enough to go upstream and recognize that individuals are falling into the river somewhere. How can I stop that? How can I intervene? Downstream interventions. Their strategic focus is on providing equitable access to care and services to mitigate the negative impacts of disadvantages on health. So, how do we begin to look at upstream interventions? We right now are at the crux of creating downstream interventions almost on a daily basis. Upstream looks more like advocacy and being able to conceptualize a case from a broader perspective and intervening much earlier. On this slide, we see protective factors for suicide. That could be coping and problem solving skills, cultural, religious, or personal beliefs that discourage suicide. We need to be looking at our implicit biases. What is meaningful for us? What is their spiritual or religious connectedness? How do we become effective behavioral health care workers? Sometimes we have to set our own stuff on the shelf to be able to do that. We need to be able to engage in self care. Perhaps that looks like our own counseling or supervision or consultation. Building our self esteem, building our sense of purpose and meaningfulness. Workplace intervention strategies that promote employee wellness. This is going to be very important. We can't always wait for somebody else to say, "Hey, let's have an employee wellness day." Maybe we as individuals need to abdicate and be role models for these types of things. How does all this manifest in client care? The client can experience counselor burnout, compassion fatigue, or vicarious trauma. The client may identify their counselor as a friend. Maybe they think, oh, my counselor doesn't care about me. They didn't want to hear about my issues. I didn't feel as though they were paying attention. They were distracted. My session felt rushed. They came late. They were distracted while I was in there. I don't feel heard. They rushed me out before I could say everything that I needed to say. It didn't feel genuine. My counselor doesn't hear me, doesn't see me. My counselor downplays my problems. Sometimes we miss these pieces because we are not well ourselves. So, talking to the client about what the client experiences and their satisfaction in session can be extremely helpful to our status as a professional helper. When we see these things happen, what we can see is treatment outcomes, and that oftentimes the client is resistant to change. I hear this frequently: resistance, resistance, not changing, not achieving goals. But is this really a fact? I would challenge you, if this comes up for you, to ask yourself, is my approach working? What does my care look like? Is my perspective or filter causing me to look at this in a way that maybe is not advantageous for the client? We see misdiagnosis. We see the lack of progress in treatment. We see the turnover in clients and that clients aren't coming back. They tell us that they're done, either with us or with the program driven treatment that we're offering. They leave prematurely against medical advice. And ethically and legally, we might be engaging in some type of fraud, waste, and abuse type of behaviors. All of these things need to be addressed. So please make sure that we are normalizing having these conversations and having conversations about the fact that we need to take care of ourselves as well as one another. We are ethically obligated to refrain from offering or accepting professional services when we are not in our best place. We have to be alert to the signs of impairment and seek assistance for those problems and recognize that there are consequences. If we fail to do that, it becomes harmful that our positions may be eliminated or suspended or terminated for various different reasons. We need to be proactive about this. It is your ethical obligation to monitor for signs of impairment. So, talk to people about signs of impairment. What does this look like? Tell others, I know myself, and when I get stressed, this is what happens. If you see these signs and symptoms in me, please let me know. Other people will see it before you do, and let your colleagues help you to recognize any type of impairment and have those conversations and have those check ins. Self care is not selfish. Let's look at the ways to be interconnected. Let's recognize that professional and self care are highly intertwined, that to have meaning and purpose and values as a counselor, how do we live our life? How do we care for our own lives? And what is our purpose? Let's have a growth mindset to become part of the solution. If we are part of the problem and we're complaining about the problem, what is that doing? Positive psychology is a way of thinking about human beings and how we can promote maximum growth. What makes people succeed? How can we create environments that allow people to perform at their best? So, this again very much is a balancing act. We have religion and spirituality and mindfulness and setting healthy boundaries, that mind body connection, seeking supervision and consultation. We really need to figure out what is going to be the best for us. We have a great quote over here by Bessel van der Kolk. I discovered that my professional training, with its focus on understanding and insight, had largely ignored the relevance of living, breathing body, and the foundation of ourselves. We need to do our own work. Maybe that means engaging in breath work and yoga. So much of what we have learned in this course is other directed, but doesn't it apply to things that you could also do for yourself as well? Oftentimes we tell our clients that they need to do this, this, and this, and maybe we need to turn that back on ourselves and make sure that we are doing this, this, and this to take care of ourselves and ensure our health. So, having that professional identity and development, that peer support, that work life balance, that religion and spirituality, all of those things, we need them highly infused into our day to day. And sometimes that means sitting in the opposite chair, getting our own counseling to ensure that we're in the best place that we can be to help others. Doing our own work is what empowers us to be available to clients. We need to do therapy because we're human, and this is very complicated work. If we do the work, we're fostering resiliency. Remember, resiliency is not necessarily innate. We can build it, we can demonstrate it, we can repair ruptures. Resiliency, building, and empathy and growing experiences are going to be extremely important to our work. So think about the ways that you can reconnect, that you can regrow in certain types of relationships or experiences. And our capacity to get back to baseline is primarily influenced by our connectedness. So the more connected we are in doing these things that provide us with meaning and purpose, the better off we're going to be. So, how do we do that? Develop your own self care plan. Perhaps where you work, you wear a name tag, and on the back of that name tag, you can always write a few bullet points about self care things that you enjoy. Or maybe you can post your self care plan in your office. Maybe you can share it with your group supervision and your individual supervision so other people are aware. But let's make sure that you do have a self care plan, and that plan consists of mind, body, and spirit, and that you are looking towards potential goals and you are relying on support systems. What are the action steps around that? What are your long term and short term goals? Asking yourself, are these realistic? We need to talk about empowering people within our place of work. And this oftentimes is through a sanctuary model of trauma informed care, which helps to promote a culture of well being in an agency and really focus on how we treat one another, which spills over into how we work with our clients. Create that type of environment and recognize that you have a role. You could engage in community meetings or suggest this in your place of work. And what we're talking about is simply having like a 5-minute meeting at the beginning of the day and asking folks, how are you feeling? Can you identify a feeling word? What is your goal for today? Who can you ask for help if you need it? Is there a goal or a thought you have for today? Self is also another trauma-informed intervention created by Sandra Blum, and it helps to look at some concerns or ruptures that have occurred in the work environment that we're exploring self. We're engaging maybe in group supervision, or we're talking about safety, emotion, loss, and a future that we're going through turnover and what this means for us. We've maybe lost friends or colleagues. Perhaps we have heightened caseloads. Maybe there was an act of violence in our community or something inside the walls of our behavioral health center. Let's talk about safety and look at psychological, physical, social, and moral safety and how this impacts us. Let's look at our emotions around that. What type of loss? Remember that change, all change, even positive change, is also considered loss. Colleagues may be moving on to quote unquote bigger and better positions. That's a loss. They're leaving. And let's talk about future. Something that comes up a great deal for us as addiction counselors is the overdose death rate and the number of clients that we lose as a result of fatal opioid deaths. There is a great loss. How do we grieve? What is appropriate? Debriefing with our teams around that, and then looking towards the future and how we can improve. Abdicate as an example, or what our needs are to help manage loss when it does occur. The other important part of sanctuary and trauma-informed care is the trauma triangle. This reenactment triangle that is on the left-hand side, this is an example of what you could easily fall into if you're experiencing vicarious burnout, compassion fatigue, or vicarious trauma. Oftentimes the helper or the counselor, they fall into the rescuer role even without knowing it. We must recognize that individuals have their own expertise, their own assets, and we cannot take away their power by rescuing them. On the other side here, we see the empowerment triangle, and this looks at how we can coach, focus on choice, connect with passion, and create that type of connection and focus on learning and growth as well as accountability. So these are the differences between burnout and compassion, satisfaction, and self-care. I want to complete this lecture by looking at one of the pioneers in the counseling field, Viktor Frankl. Everything can be taken from man, but one thing, the loss of human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. Let's challenge ourselves to change ourselves and to really understand that we have the power in our attitude and what we do around a given set of circumstances. Let's explore compassion, satisfaction, connection with the purpose for doing this work. He who has a why to live can bear almost any how. Thank you for your time. I hope that these lectures were impactful for you, that they helped increase your competence and your confidence, and that you understand the significant importance around engaging in self-care, again, because our field is so other-directed. And as substance use disorder counselors, we're often faced with a lot of loss. So here I have a handful of resources for you. Please keep these in your back pocket if there's ever a time that you might need them.